Okay, great. Aubrey, let's go to the next slide. I think in the essence of time, we can go ahead and get started. So welcome back everyone who's joined a session previously. Welcome to those of you who are new to the West Africa Regional PrEP Learning Network. I just wanted to give a brief introduction to CHOICE, particularly for those who are joining us for the first time. CHOICE is an 18-month collaboration funded by USAID in partnership with PEPFAR. This funding comes through two central mechanisms, the EPIC project and the RISE project. And CHOICE is a collaboration between these two projects to help address technical gaps and support national scale-up of ARV-based HIV prevention products in PEPFAR countries through catalytic evidence generation, translation, and research utilization. So CHOICE is led by FHI 360 and JPIGO in partnership with Afton Bloom, Avenir Health, LVCT Health in Kenya, and Pangea Zimbabwe AIDS Trust. Okay, next slide. So we started this learning network in July. We've been having these monthly sessions focused on PrEP introduction with a specific focus on PrEP introduction in West Africa particularly. And so you can learn more about this network at the link showed on the screen here. And we're also very open to ideas for session topics, questions, or thoughts on PrEP rollout using this email, westafrica@prepnetwork.org. So PrEP Watch does have a whole page dedicated to this learning network where you'll find previous session recordings and registrations for the next learning session. So each learning session you do have to register for specifically in order to get the participant link. If you're here, you figured that out. But we do require a registration, and then the link to join the webinar is automatically sent out once you've registered. Okay, next slide, please. So key topics for the webinar series focus on this oral PrEP introduction framework, and session topics are going to fall into one of these 5 buckets: planning and budgeting, supply chain management, ring delivery platforms, uptake and effective use, and monitoring. So these early sessions have really started focusing on the earlier phases of planning and budgeting for oral PrEP rollout. And so this includes national and subnational plans, and guideline development. I think after today's session, we're going to be focusing on topics that are a little bit further down the line in other buckets of this framework. Our next session will be on different delivery models for PrEP, for example. Okay, next slide. So our agenda for today, we're going to just introduce PrEP implementation plans, looking at why we're advocating for their development, what they are really and what they may contain for content, how they're different from the guidelines. We will introduce the Plan for PrEP Toolkit, which is a toolkit that our team has developed under the Options Consortium and the Options Project, which ran from 2015 to 2020. We'll take some questions on implementation plans generally, any questions people have on the toolkit, and then we'll go into a country panel and discussion with experiences shared from Kenya, Zimbabwe, and Ghana on their experience developing PrEP implementation plans for national rollout. And this panel and discussion will focus on these 3 questions: what is included in the plans, how are PrEP implementation plans developed, and what has been learned through this process of PrEP implementation planning. And then we'll have the wrap up. Next slide. Our panelists today will include Robin Akel from USAID, Nirja Bavaraju from Afton Bloom, who's also part of the CHOICE project, Definite Namo from PSAT in Zimbabwe, also part of the CHOICE project, Patricia Jekonaya from LVCT Health in Kenya, who's also a part of CHOICE, and Tiffany Lilly from FHI 360, working with the Ghana team. Great. The next slide. So just a quick poll. We have about 30 participants on the call right now. Please let us know, does your country have a PrEP implementation plan in place? That screen should pop up for you. And so I'll give everybody a chance to respond. Okay, about half the people have responded, and 50% of those people have said yes. 3 people saying it's in process, 1 no, and a few don't know. No problem. Great. Oops, sharing the results. Okay, and just going back to the chat here, welcome everybody. It looks like we have people joining from Nigeria, Kenya, Togo. And I know people have introduced themselves at the start. I believe we have somebody on from Cameroon and Ghana. Great, welcome everybody. Okay, so the introduction of PrEP implementation plans, I'd like to turn things over to Robin to introduce these plans. Go ahead, Robin.
Hi, everyone, and thanks so much for joining. It's exciting to see such a variety of countries joining this webinar, and I hope you all get a lot out of it. I'm just going to very briefly introduce what implementation plans are and why we need them, actually in the reverse order. So why are implementation plans needed? I think we all know that clinical guidelines can cover a variety, well, not a variety, they cover a core set of information and guidance. Some can be quite extensive, including lots of information on counseling and talking about how PrEP should be rolled out in a given country, but many are only a couple of pages long and integrated into much larger clinical guideline documents. So implementation plans are really great because you can fill in any gaps that are not covered in those clinical guidelines. It also allows you to create a document to map out how you'll launch your sites and create expansion schedules. So you might only start with a handful of sites and know that you're going to be expanding out to the rest of the country. And so it's helpful to map out what that looks like and figure out exactly what resources are needed for that, what you need to do in terms of training, how you need to plan for commodities and ordering of commodities and ensuring that they're coming into the country and traveling across the country in a timely manner, and also allocate responsibility and accountability so that you know who is responsible for what, whether it's a department or a particular person, and then they know that they will be held accountable and people will be coming to them if something's not working out or if there are questions. And so this really just allows you to ensure that all aspects of PrEP service delivery are thought out, planned for, and accounted for in advance. Next slide. And so at USAID, we developed earlier this year kind of a template outline of an implementation planning tool. We called it the PrEP Implementation Scale-Up and Acceleration Plan because we wanted to develop a document that would allow for countries that are newly starting or in the early stages of starting PrEP implementation to have a guide and a template into which they could incorporate all of the relevant information. But also many countries are in a phase now going into COP20, which starts in just a couple of weeks, where they're going from maybe a few thousand people on PrEP to in the tens of thousands of people on PrEP. And that's a huge jump. And actually, many of the same components are needed for both new implementation and acceleration. So this document that we created helps to support plans for scale up and acceleration, moving from smaller phased approaches to wider implementation. It provides a template that takes into consideration each component of PrEP implementation. So this is a snapshot of the table of contents here. And we did not include the appendices, but you can add in whatever you want. And this is really just the core set, but as we note in this last bullet, it can be adapted to meet any partner or country needs. So really this is meant to be a template, and you can fill in whatever is relevant to your context. I think the other thing that I wanted to mention too is that this can be used on any level. You could use it on a national level, or you could use it in a site. If you wanted to just do something for a particular site, you could use it as in a partner level or an agency level or interagency level. So it's really meant to be really flexible, and you can kind of adapt it in whatever way makes most sense for you. And I think that's it from me. Can't hear you, Katie.
All right, thank you, Robin. I'll turn things over to Nirja now, who will go through the Plan for PrEP Toolkit. And as I mentioned, this toolkit was developed by the Options Consortium. It has different modules, and each of these tools is aimed at helping support PrEP implementation and planning. You'll hear more in just a minute from colleagues in Kenya and Zimbabwe who have used some components of this toolkit to help inform their implementation plan development process, help determine who they're rolling out PrEP to, where, what geographies, at what time, and particularly with a phased approach, how to aid in that decision making. And so I'll turn things over to Nirja to go through kind of the elements of this tool, and then we'll hear a bit more about how they've been applied in Kenya and Zimbabwe a bit later on in the webinar. So go ahead, Nirja. Thanks.
Thanks, Katie. So exactly as Katie mentioned, the Plan for PrEP Toolkit was developed in the work in the Options Project in close partnership with stakeholders in Kenya, Zimbabwe, and South Africa. And that includes our partners who are in those countries, as well as other stakeholders, including Ministry of Health officials, who really informed the development of these tools so that they were really addressing particular needs that the stakeholders had. And the toolkit includes a set of 6 tools overall, which I'll go through in a moment. And then we'll do a really focused look at 2 particular tools that may be helpful to people. But the last thing I'll mention is that the toolkit is available online. It's on PrEP Watch right now in English, and will soon be available in French as well. Next slide, please. So the 6 tools that are in the Plan for PrEP Toolkit are laid out here. The first was a situation analysis. So this was a tool that we will go through in a moment that really helps to provide a framework for PrEP introduction, and is almost a good checklist to see what needs to be done and what you need to think about for introducing PrEP. And that's really based on the experiences in other countries. So that's the first tool, and we'll go through that in more detail. The second tool is a project landscape, and that is probably less relevant for most of the participants on this call. It was really helpful in the early days of PrEP when there were lots of demonstration projects, and we were aiming to look across different projects to understand what was actually being done and what was being learned from those projects. The third tool is the rollout scenarios, and I think this tool will be quite relevant for this group, so we're going to take a close look at it in a moment. This is a tool that helps to take whatever data exists in your DHS systems or HMIS systems and try to develop different plans or scenarios for how to roll out PrEP. for example, by focusing on particular regions or particular population groups, to understand what are the trade-offs between those different options, especially as countries are considering a phased rollout. So starting in a subset of places and then expanding onto others, as Robin shared. So we'll be looking closely at that. I will briefly mention the other tools that are in the toolkit. So tools 4, 5, and 6. Tool 4 is to support the development of kind of district or county or province level readiness for PrEP. This was particularly relevant in Kenya for our Kenyan partners, where they have a more devolved healthcare system. There's also a facility readiness assessment that was developed based on facility readiness assessments from multiple countries. And there's both a kind of more basic version of that is simpler. And then in that tool, there's also a more comprehensive version. So you can kind of pick which version suits your need best. And then the final tool is a private sector assessment tool to assess which private sector channels may be most relevant for PrEP introduction in your country. So those are the 6 tools, but what I'll do now is go provide a bit more of an overview of tools 1 and 3. So if we could go to the next slide, please. And I sincerely apologize. There's some very loud birds in right outside my window. So I apologize if you're getting some of that background noise. So this framework is the framework that Katie just went over at the beginning. It's a framework that underpins all of the tools in this toolkit to help us just organize the different elements of PrEP rollout. So starting with planning and budgeting, onto supply chain management, through actual delivery, uptake, and monitoring. And if we can go to the next slide, you'll see how we use this framework in multiple ways. Aubrey, could you go to the next slide, please? So here's the first way in which we use it. So you'll see here that under each of the 5 categories, there's actually detailed activities that sit below that. And these are all based on the experiences in other countries with PrEP rollout. So you can see here, developing an implementation plan is certainly one of the tasks. Planning for training of healthcare workers, developing information for PrEP clients. So this almost serves as a guide, and what we have in the tool and how we'll hear this tool was used in Kenya and Zimbabwe is to actually track along these different activities where the country is on making progress towards them. So this is just an example where some of the ones in orange are in early progress, some of the ones in green are kind of complete or there's significant progress, and then some of the ones in gray have not yet been started. So that's an example. I think this tool was quite useful in getting different stakeholders aligned on where PrEP rollout was and what still needed to happen. So it was quite useful, for example, for a technical working group. Next slide, please. This is another way in which we use the same framework to just identify, based on stakeholder consultations or discussions amongst the technical working group, what do we expect will go well with PrEP rollout, and what do we expect will be challenging with PrEP rollout down on the bottom. So we should pay attention to that and address it in our plans. Next slide. We also, in some of the countries, really landscape the different stakeholders who are relevant. This is an example of Zimbabwe for different parts of PrEP rollout, so that this can be helpful in thinking about how you engage different stakeholders, who needs to be part of a technical working group, for example, as you're getting started in PrEP rollout. Next slide. And then finally, we also identified in each country, what are the real questions that people have about PrEP rollout? And this was developed for, this example is a few years ago. So some of these questions have been answered with early PrEP rollout, but we know that every country will continue to have some initial questions that you want to explore as you're going through initial PrEP rollout. And so this provides a way to really just identify those questions and then track lessons learned against them as you're going along in the early stages of PrEP rollout. So that's the situation analysis tool. Aubrey, next slide. The second tool that I wanted to go through is the rollout scenarios tool. And this is a tool where what we did was take in whatever data or information countries had available. So not developing new modeling analyses, but rather just using what data was on hand and trying to do some analysis with it to think about what that could mean for where to roll out PrEP first, or how to roll out PrEP. So this chart is an example of Kenya. You'll see that the data that they had was on the x-axis here. They had whether they had a sense of the presence of key populations, or the extent to which key populations were driving the HIV epidemic across different counties. And so we used that on the x-axis, and then we used HIV incidence rates on the y-axis, and then the size of the circle represents the number of new infections. And I know that this is a bit small, but we can certainly share this after the session as well. But what we did with this analysis was just to plot different counties, so that you could get a sense of which counties have high HIV incidence, but also have, for example, a lot of key populations. So you might think about prioritizing that county, but with a focus on key populations. For example, here you see a few counties that are in the upper right-hand side. So that, like Homa Bay here, which you can see, which is this dark green circle, that means that it has a high HIV incidence, but it's actually generalized amongst the population. It's not specific to key populations. And so that means to us that you might want to invest in a general availability of PrEP in that county. On the next slide, you'll see the way that we actually then use this. So we actually took these different, this mapping, and developed a few different scenarios. Thank you, Katie, for sharing the full link to this, this analysis. So we looked at, for example, what would it mean if you just rolled out PrEP to those counties with the highest rates of incidence? Or what would it mean if you rolled out PrEP to those counties with the highest numbers, absolute numbers of new infections? And how many of the new infections are actually coming from those counties? And what is the level of population in those countries? So what can we get a sense of for how much that would actually cost? And of course, this stops short of being an actual cost effectiveness analysis, but it gives us some idea of different scenarios that we might actually want to go develop cost estimates for. So that's the second tool that I wanted to provide a brief overview to. And actually, maybe Katie, to your point, Patricia, as we're on this topic, if you're able to, would you want to just share briefly how these tools were used in Kenya?
Yes, hi, and thank you very much, Niraja. I think some of the tools that I'm proud of during the rollout of PrEP in Kenya were the tools that were developed in the Options Consortium. Because they really came in handy for us as a country. First, the situational analysis helped us identify the strengths and what we already have, what resources were already available, what was there in facilities within the county governments, the devolved systems, and also to help us identify the gaps that were still existing across that value chain. And with the gaps, we utilized that to prioritize what would be the main things that we needed to really address, and for us to be able to just roll out PrEP and keep improving over time. And then the rollout scenarios, I think I would call them the favorite, because to date, people still ask us for them. It made us understand the epidemic in the country, how it was spread out, who are the drivers in those counties. So if we are to take PrEP in a particular county, how would we do even the demand creation? Would we have to go specifically to the population where the new infections are coming from? Or should we have a more generalized approach? So that was quite useful in helping us to target more and to know which counties we should actually prioritize if we are going to get a greater impact. So for Kenya, I think we had about 5 scenarios, and we chose one scenario that had about 19 counties to start with. And then we gradually included the other counties over time, also based on the resources that were available in the country at that time. And for the facilities and the county assessments, for us again, because devolution came in 2010, so we knew there were certain disparities within counties. And as we were prioritizing the counties, it was important that the first 19 counties would also be assessed, their facilities assessed, to see the kind of investment we need to put in to get us started. So the assessment equally really helped us to be able to define where the major investments would go into at the beginning and continue scaling up over time. So these were major decisions making tools, and the implement. Over, did you hear me?
Yes, I can hear you now. It did cut out a little bit. Did it cut out for anybody else?
Yes,
It did
just
a
for a
little,
few
Katie, yeah.
seconds.
Okay, just for a second. I think we're okay though, unless there's questions for Patricia or if she needs to repeat anything. Okay. Great, and Definite, I think you are on the phone from Zimbabwe, and you also use these tools in Zimbabwe. I don't know if you have anything more you'd like to add to that.
Thanks, Katie. Thanks, Niraj and Patricia, and hi, everyone. So just to speak a bit about how we use the rollout scenarios in Zimbabwe, when we did our guidance, we then started thinking of how we should operationalize the PrEP guidance. And because we did not have all the resources we needed to roll out PrEP to anyone who needed it, who thought they would be like at high risk of contracting HIV, we utilized the rollout scenarios that we developed through options. And part of the data that went into the rollout scenarios for Zimbabwe was we had just done a hotspot mapping, which was looking at which geographic areas have the highest HIV incidence. And we had also done the modes of transmission study, which looked at which populations are at higher risk of contracting HIV compared to other populations. So these were the two critical documents that fed into our rollout scenarios. And for the rollout scenarios, we tried to balance between geography and HIV prevalence in geographic areas. So it was a balance between geography and population. How would we do that? And we came up with, I think there were 4 scenarios, and we ended up choosing one that helped us make a decision on making having PrEP be done in a phased approach, where we started with the central levels So the central level is the highest level where you have the most doctors, the most nurses. So you have the most healthcare providers, the most number of healthcare providers who are qualified at the central level. And we thought we'd start with the central level in case we'd have adverse events, at least it would be easier to manage from that level. So from there, we then did the phased approach from the central right down to the clinic level, the rural district level, where we are now delivering PrEP. But we started off in that phased approach where we started at the central level. So that's how we use the rollout scenarios, unless if people have questions. Thank you.
Thanks, Steph. Any questions from the group on these tools or the overall toolkit before we dive into the panel discussion?
Hi, this is Tiffany. I have a question for Kenya and Zimbabwe. How did their conversation go with commodities and matching that with scale up in the different scenarios?
Thanks, Tiffany. Maybe I can start. So for Zimbabwe, what we did was when we're developing the rollout scenarios, it was in consultation with the technical working group, which was spearheaded by Ministry of Health and Child Care in Zimbabwe. And as the various scenarios, as we're toying around the various scenarios, where to start delivering PrEP, the supply chain department was also part of the technical working group, and they were part of the decision-making process at that point in time. And part of the decision to start at the central level was really informed by our supply chain system, where the supply chain unit advised that it would be easier to start at the central level because they are well stocked at the central level, and we always make sure, because these are the referral facilities, they always have the drugs in stock. So because part of the drugs that that are used for PrEP are also used for ART, they made sure that the central facilities are well stocked and they do have provision for PrEP. So that's how those decisions were made. They were a part of the decision-making process. They were part of the TWG from the beginning as these deliberations were going on and as the decisions were made. Thank you.
So in the Kenyan context, we had different things coming into play. One, we had the trends that came from the demonstration studies to see the uptake of PrEP, and how were people, coming back for PrEP to tell us, like in terms of when we're doing demand creation, what sort of percentages or numbers of people would we be expecting to actually take up PrEP? So that came into play, but then also the number of new infections in the country at that time. I remember we had about 100,000 new infections in that year, 2017 there. And so utilizing the trends that came from the demonstration studies, plus the new infections in the country at that time, we utilized that to be able to try and have an estimated target. And then we worked with the procurement team, the supplies, to be able to see how much of PrEP would be required to at least be able to meet the needs of the different populations. So I must say that initially it was a bit of a challenge because we were not so sure in terms of what uptake would look like. And so the first 3 months were actually months of learning. There were areas where the quantification was actually less than the demand that was there. And so quickly the country, the procurement team were just able to reassign PrEP in areas where they had given more and the demand was less. So what I would say is that there's a lot of monitoring that's required, probably in the first initial 3 months or so, to just tell you the trends and what's working in different districts or provinces. And there can always be that the reallocation of PrEP where it is needed or where the demand is higher.
Thanks, Patricia. And quickly before we move on, did either in Kenya or Zimbabwe have a limit on how many they could initiate? The question from Tiffany.
How many at a time, or how many in terms of per facility, per provider?
Tiffany,
yeah, sorry. Hi, this is Tiffany. Just at the national level, did you have a limit on how many individuals you can initiate based on the supply?
Yes, and this now is the target. So yes, at national level, at the level of the technical working group, we set a target. And I think our initial target was about 87,000 people per year. And that then kept on being revised based on the uptake. So yes, there was a limit that was informed by the number of new infections in the country at that time.
And for Zimbabwe, through the technical working group, we also had targets that we set per population. For example, we had so per population per year, because our initial implementation plan was running from 2018 to 2020. So we had targets for female sex workers, serodiscordant couples, men who have sex with men, adolescent girls and young women, and young women in general. That's the 20 to 24. And this was informed by the demonstration projects that had taken place prior to this process. And we made estimates based on the number of people who were coming in to access PrEP through those demonstration projects. So this was the DREAMS project and the demonstration project that we conducted among female sex workers in Zimbabwe. So the findings from this demonstration projects helped inform the targets. And for example, we had an average of about 10,000 people to be initiated on PrEP per year. And it's stratified per population group. And just to say that for the first and second year, we failed to meet these targets. So there's a lot of regrouping and having discussions that goes on. And like Patricia says, it's a lot of learning. So for the first 2 years, we missed the targets that we had set as a technical working group being spearheaded by Ministry of Health. But I think what then happened was, as the years went by, we kept refining the how we were doing the focusing for the targets. And I think we've become better at focusing how many people will be initiated on PrEP per year per population. Thank you.
Thanks, Steph. And I'd like to go to the next slide just to start our panel discussions on the implementation plans more specifically. But just a note for the group that we are talking about PrEP costing and target setting more specifically in our December session, as well as some tools to help support that process. So stay tuned for more information on that topic. Okay, next slide, please. So now we're going to get into the key topics in implementation planning. What is included in the plans, how are the plans developed, and what have we learned about PrEP implementation planning. And we will hear more from Tiffany in Ghana, Definite in Zimbabwe, and Patricia in Kenya on their experience engaging with the development of the national implementation plans for in their respective countries. Next slide. So starting with the first question, what is included in the plans? Patricia, I'll ask you to go first, and then I'd like to hear from Definite and Tiffany on things to add or differences in their content of their plan. So Patricia, I'll turn it over to you, please, from Kenya.
Yeah, thank you. So for the Kenyan implementation plan, we have some content giving the journey of PrEP implementation in Kenya. So like how many demonstration studies were there. And then there's a situational analysis findings, which is a tool that I had spoken about before, giving the key strengths and resources available and the gaps that were there at that time. And then it also provides an overview of the 5 different approaches for PrEP scale-up that was really informed by the rollout scenarios. So we got data from all the counties and put that to bring in the 5 different scenarios. And then it focuses a lot on these key 5 objectives around availability, acceptability, accessibility, integration, and impact. And it has 7 key areas on leadership and governance. And the leadership and governance focuses on coordination of HIV and PrEP responses at all levels. So national, county level, community level, what is the role of leadership in those different levels. Then on service delivery, the focus was largely on identification of PrEP clients for initiation, the client flow, the mechanisms for implementation of PrEP, capacity building for providers, and data management within facilities. We also had commodity security, which focused largely on availability and supply of high quality and correct quantity of PrEP products to the potential users. We had a section on communication, advocacy, and community engagement, which really focused on awareness creation within communities, how to engage communities in successful implementation of PrEP, and also issues around demand creation. And then we had monitoring and evaluation that was on tracking, measuring progress, product impact, and having informed decision by utilizing the data that's available. We had another focus area on research and impact evaluation, which defined the strategies for formulating, conducting, coordinating, and funding implementation science in the context of PrEP. So we had key research areas that we really wanted to continue doing even as implementation was starting. And finally, we had the focus area on financing and resource mobilization that focused on the estimated resources that would be required and mapping out where this funding would actually come from to ensure that the implementation of PrEP is ongoing. And this plan was done at the level of the technical working group. Thank you.
Thank you, Patricia. Definite, anything more you'd like to add, or any differences in what was included in the plan in Zimbabwe?
Yes, thank you, Katie. So for Zimbabwe, what we looked at as we were developing our implementation plan was looking at what would be the overall goal of developing this implementation plan. And our goal was really to introduce PrEP as part of combination prevention, as well as reduce the HIV incidence rate across all populations. And with this, we came up with 6 main objectives, which I'll speak to briefly. So the first objective was looking at how would we do this. So obviously we needed to build the capacity of providers. And by building capacity of providers, we needed to equip the providers with the knowledge and skills to provide PrEP. And this entailed training, coming up with training materials for providers that were uniform across the country, because prior to this, what was happening was each implementing partner was developing their own training materials. So we sort of reviewed what was available, and these materials were standardized at national level, such that if anyone was trained, it was through the national training materials. Then the second objective we had was to strengthen coordination and management structures of oral PrEP. That's the management and coordination. So at national level, through the TWG ministry, needed to make sure that there is a coordinated approach to delivering PrEP. We need to understand who's getting PrEP, where, and how they're getting PrEP, how that coordination process was happening. Then the third one was really in terms of increasing awareness and demand for PrEP, raising PrEP awareness, promoting PrEP use amongst the various populations. And the fourth objective was to strengthen generation, coordination, and implementation of PrEP. By this, we tried to come up with monitoring and evaluation systems that would work across the country, across all populations. So we also had various committees that looked specifically at the M&E systems, how this could be integrated into the existing M&E structures that were already in place at national level. Then the fifth objective was to ensure continuous availability of PrEP medicines and related commodities. So this was the supply chain. And like I said earlier on, they were part of the process from the get-go, because there was no way we could set targets without having the supply chain unit within this TWG. So we needed to make sure that what resources did we have available, how much PrEP was available, how many people would we be able to deliver PrEP to, given the resources that we had. And then the last one was really about increasing access to PrEP, both in the public and private sector. So we needed to increase the number of implementing partners that were delivering PrEP. And importantly, we also had a partner that was doing the costing of this implementation plan. They were also there from the get-go, because we needed to understand how much it would cost for us to deliver PrEP, and how much you could afford, how many people would be able to afford to deliver PrEP to. And this is where the target setting also came in. So this is how we did our PrEP implementation plan. Thank you.
Thanks, Steph, and I'll turn things over to Tiffany to share the Ghana experience.
Good afternoon, everyone. I hope you're doing well. So I think, yeah, it's wonderful to hear Kenya's and Zimbabwe's approach and using objectives on the national level and really driving implementation and scale up. In Ghana, we had a bit of a different approach based on implementation realities. There was a policy in August 2019 that was published for HIV care guidelines, and PrEP and HIV self-testing were contained within those guidelines. So there was a lot of energy and excitement about rolling out PrEP at certain geographical areas based on PEPFAR implementation. So JSI is the one PEPFAR implementer in Ghana, and then through FHI, we have the Key Population Investment Fund, which was supporting this national level dialogue and process. We also had a TWG and implementation committee with various stakeholders, NACP, the Ghana AIDS Commission, WHO, UNAIDS, JSI, FHI, and our sub-partners, Global Fund, that were a part of the consultation and input. And I would say that we were lucky, FHI as implementers, to be a part of this river of excitement to really drive the implementation. So our implementation framework is for a jumpstart strategy. So within the PEPFAR program, so FHI and JSI. So we are in more the infancy stage, and then taking these lessons learned to augment our current implementation strategy. So based on this level of implementation, I would say we didn't contain these components that Kenya and Zimbabwe included with capacity building and management and demand creation and service delivery, dosage, some of the basics of WHO guidance in the science and the context. But given that this implementation strategy was for the jumpstart phase, we have additional appendices that have forms, eligibility criteria that help guide implementation at the facility level. So I think in addition to what Kenya, Zimbabwe provided, we have more the SOPs and tools that help guide implementation at the ground level that might not be contained within a national implementation plan. Thanks.
Thanks, Tiffany. That's a nice juxtaposition of your approach. Let's go to the next slide, and we'll jump into the next question. How are PrEP implementation plans developed? So we'll start off with your experience in Kenya, and then we'll go to the other countries for more to add on that.
Thank you. And as I had alluded to before, the implementation plan was developed at the national level with the PrEP technical working group that is still spearheaded by the National AIDS and STIs Coordinating Program. And the TWG was organized into 5 subcommittees that included the service delivery, commodity security, communications and community engagement, monitoring and evaluation, research and costing. And each of these teams were asked to develop content for the implementation framework, giving clear recommendations. First of all, the clear goal for that particular section in the implementation plan, the objectives of that section, and what was actually being recommended. So all that, we put it together, and then there was a smaller team that was identified from the larger technical working group. And so at that level, we went through all the content that had been developed by the different subcommittees, reviewed and also put in any additional maybe processes or objectives that we felt had been left out. So we finalized the content of the framework, shared it again with the technical working group and the head of NASCOP at that time, and a number of other development partners in the country. We had WHO also reviewing these components, and people from PEPFAR also went through the implementation framework, gave us the feedback. We finalized it, and it was launched when we were launching the national rollout. Thank you.
Thanks, Patricia. Definite, go ahead for Zimbabwe.
So for Zimbabwe, we more or less followed the same process as Kenya. The process was led by our Ministry of Health, and we had a technical working group that had representation from the research, academia, implementing partners, civil society, adolescents and those and young women, and other key populations. So this was the representation for the TWG that gave oversight to the whole process. And from there, we had various committees that were formed for specific tasks. For example, we had a committee on communications, so advocacy and communication, demand creation, monitoring and evaluation, and costing. And this whole process was very consultative in nature, and the policy makers, which is really the Ministry of Health, we're in the room at any given point in time, and this helped to make sure that everything is progressive and we are not going back and forth, because some representatives are not in the room. So we made sure that whenever a meeting was set, the policymakers are also there, implementing partners are there, researchers and end users are there. And part of what also informed our implementation plan was some implementation science that had been done through options prior to this. So we had done a knowledge, attitudes and practices survey that looked at, that was targeting providers and to identify what gaps were there among providers. We had also spoken to potential end users through community dialogues, and we wanted to understand how much information was there around PrEP, what were the gaps, what were the myths and misconceptions, and we also had the research that had been done through clinical trials around oral PrEP, both in country and also globally. So all this information was coming together for the TWG, and this is how we developed these plans using evidence that was available and evidence that continued to be generated during that process. I think importantly, during that process, we also conducted in-depth interviews and key informant interviews with providers, gatekeepers, and users to try and fill in the gaps where we didn't have information at national level. We filled it in via the IDIs that we did and the key informant interviews that we conducted during that process. Thank you.
Thanks, Steph. Tiffany, go ahead for Ghana experience, please.
Yeah, wonderful. Good to see you guys again. So yeah, it's impressive on the amount of work that Kenya and Zimbabwe have done to really develop their plans and have the larger research and target setting and implementation to feed into their national plans. And that's where we really do hope to go. But I think it's helpful too for Ghana to share their experiences, given the infancy where we are, and many countries are in our same position on really how to start the process, which can seem overwhelming. And it's good to, to have the building blocks and have the various consultations together to really get where we need to go. We did, so JSI, so in 2019, in August, that we had the National HIV Care Guidelines. And before that, JSI did implement a feasibility assessment with various stakeholders to gauge their interest and acceptability for PrEP implementation. So using that background and the energy of the policy and excitement around PrEP implementation, we were able, with USAID support, and we appreciate the leadership on USAID Ghana's side, to really create this national level PrEP and HIV self-testing implementation committee to really help guide the virtual consultations and using some of the resources out there on the national implementation plans, and using the basic building blocks and outlines to really frame what we were able to produce. So we did have virtual consultations. I think all of us, when we were starting to really drive the implementation framework, we were hit with, as all of us were, with COVID-19. So more the traveling and in-person consultations were challenging given people social distancing and meeting in groups. But we were able to lead those virtual consultations because everyone was working from home and had access to internet. And if those did not have access to internet, to bring them to a location where social distancing was possible, and we could have that dialogue and include components and their ideas into that national level framework. And then we had various iterations of the implementation guide based on the outline and inputs from the team. Even last week, we received more comments. We are at the ground level at maybe part A. So we're implementing learning lessons learned from like cost of commodities, target setting, cost of the labs, and then we'll roll that into the larger national framework. But it's good to have somewhere to start, and then have the phased approach, just as Zimbabwe mentioned that they did go through the costing and target setting, and through 2 years of iterations, they were fine tuning. So it is a step-by-step process, but we have somewhere to start, and we're looking forward, of course, to growing and expanding and having more of a national level scale up. Thank you.
Thanks, Tiffany. And Robin has raised a really good point, and Tiffany has brought this up too. The extent of the inputs that have gone into the Kenya and Zimbabwe national plans is quite extensive, and many countries are not in a position to be carrying out research to inform the plans and that sort of thing at this time. And so I just wanted to note that there are ways to fast track this without carrying out implementation science research and doing a lot of the extensive analyses in the beginning. And I think Tiffany raised a good point, is starting with what you have and then continuing to build on that over time, and from lessons learned, expand upon that framework and that plan and build it out more specifically. Patricia or Def, I don't know if there's anything that you want to add, or just, I know that there's some correspondence going on in the chat, but if you wanted to talk through any of that in response to Robin's comment, we can take a minute for that.
I think I have pointed out in the chat that there's already a lot of information, studies, and evidence that's already been conducted that you can start from and not have to do like a whole implementation science research. So you can start from what is already known, and then engage maybe communities virtually to just get their input into what can inform the implementation framework. And then with the technical working group, you can assign based on strengths. That's what we did, identifying the different members of the technical working groups, their areas of expertise, and assigning them components of the implementation framework to start working on. And then we got also input just from talking to communities, which I think is something that you can also do, and just pick from research that's already existing. Thanks.
And Patricia, I know what a huge lift it was to get these implementation plans launched. And I don't know if you could speak a little bit in terms of like, how long did it take to put together? How frequently were the teams meeting? And I think you just alluded to that different people were assigned to different parts of the plan, and these subcommittees were established, and then I think the full group came together periodically to discuss overall. But maybe you could expand on that a little bit in terms of that. Go ahead.
Yeah, thank you. So we held, I think, our first meeting to discuss the implementation frameworks in November of 2016, and our launch happened in May. So in November, we set up the different, we tasked the different subcommittees with the work to start developing content. The subcommittees met almost every 2 weeks and were reporting to the main technical working group on a monthly basis. And then when we got to the month of March, the smaller working group, we used to meet on a weekly basis to review the content and get feedback also from the teams that worked on it. And when we were nearing the launch, I think somewhere mid-April, we met daily for an entire week to just finalize everything and ensure that we had our printouts ready by the first week of May. The launch happened on the 7th of May. So initially, there are those meetings that subcommittees organize by themselves, but we had consistent monthly meetings from November, and then more frequent meetings from March, and a daily meeting in April to just conclude. So it was quite a lot of work. Thanks.
Aubrey, can we go to the next slide? Thanks, Patricia. I just want to make sure we're going to save some time at the end for questions. So what have we learned about PrEP implementation planning? So yes, please go on, Patricia. We'll start again with you and then go on to Tiffany.
All right, yeah, so from the time we started the national rollout of PrEP, things that we've learned is to, initially we kept on going back to the research, the evidence and international guidance that kept, coming out at that point, to refine our plans, to refine our rollout within the different counties. And the success of this is that what we realized is that communities kept on, going back to the evidence. So we had this debate at the beginning, should we tell people about the side effects? And others are like, if you tell them the side effects, they will not take PrEP. But communities were coming and saying, we know these are the side effects. So going back and ensuring that whatever information we're providing to communities were actually in tandem with the evidence and the research that was already out there and the guidance that was also coming. The other thing was involvement of key stakeholders. And because we know PrEP was targeting people, and these people, a lot of times we are working especially like for key populations that are already criminalized communities. So there was a feeling at that time that people often violate their human rights, that we don't involve them and yet we want them to take a product. So to streamline the delivery of PrEP, we ensured there was a lot of engagement. Even as we were planning demand creation in a number of areas, they were led by the communities themselves. And we needed stakeholders, key decision makers to understand the role that PrEP was playing in the HIV response in the country, so engaging them all through. And then planning according to the varying context. Our countries are very different, and even within the countries, we had areas of generalized epidemic and the others that were concentrated to specific populations. So taking that into consideration helped with identifying how PrEP should be delivered to which populations based on the epidemic. And also having a phased-out approach was also quite useful. We had a lot of learning in the initial stages, and a lot of those mistakes that we did with the initial counties were never repeated in the others. And we ensured that there was a lot of learning and exchanging of experiences and the learnings within the counties and also the service providers. And capacity building for healthcare providers is something that we cannot overemphasize. For us, there was the initial training of TOTs, and then a few of the providers were trained. And when we did the knowledge, attitudes, and practices study under options, we realized a number of them were actually providing PrEP without training, which was not actually working. They had a lot of dropouts in PrEP. And we brought this to the attention of the national government to just ensure that the training is cascaded to all providers who are expected to give PrEP. And also training providers to understand the needs of the different populations that are being targeted. So for us, we even had to do like a key population friendly friendly service provision training, and adolescents and young people friendly service provision to the different providers. And finally, funding. Availability of funding for us really determined a lot of the things that we could be able to do, and determined even the kind of impact that we had, eventually, and really determined also in terms of scale, how far could we go? So knowing the resources that you have at the point where you're starting the rollout really helps with the planning, helps you to know to what extent can you go, how widely can you spread. Thank you.
Thanks, Patricia. Daphne, do you have anything different to add based on your experience in Zimbabwe?
Yes, sure. Thanks, Katie. So I think for us, what we learned in Zimbabwe was that this was a very consultative process. And before starting the implementation planning process, it's important to map out who your key stakeholders are. because what we found out as we're going through this process, there were some key stakeholders that we had left behind. For example, we had to rope in adolescent girls and young women. We had to have representation from men who have sex with men. And these initially had not been part of the core TWG. So it's important to just sit back and map out who your key stakeholders are for the process so that you make sure the process goes well and no one is left behind. The other thing we learned was that it's important to work with committed and engaged people such that the process is smooth. If you do not pick out your stakeholders in a strategic manner, you'll find that there are some people who come for this meeting today and maybe next month when you call for the meeting, they are not there. So there is no continuity. And every time you have to go back again and revisit where you started from, where you are in the process, what else needs to be done. So it's important to have focal persons who are available, who are not too busy. So it's important to have the critical skills you need for the implementation plan, but also have people who are available to put in this work, because it is a lot of work, and people who are not too busy for when you plan for meetings, they don't pitch up. So that sort of lengthens the process. A process that's supposed to take a month might end up taking up 3 months because the people are not available. They are too busy, they are too spread. And it's important to make sure there's buy-in from the decision makers. So we did have the various committees that were given specific tasks, but they had to come back and report to the full TWG. But at those meetings, it's important to make sure the decision makers are a part of that meeting, because there's no point in having the committees come back and report back to the team. And when the decision makers come, they'll say, oh, we did not approve that. So you've had 3 steps forward and you go back 2 steps. So that's very retrogressive. And we also had the costing team being a part of all these subcommittees so that they had a full understanding of the proposed activities, and they were able to cost the activities in full. What we also had was we made sure we had WHO representation, we had representation from our therapeutic committees, PEPFAR, CDC, because it was important to understand part of the decisions from the global perspective, from the donor perspective, from our therapeutic committees perspective, what was allowable and what was not allowable from their perspective. So for us, I think those were the main lessons we learned from that whole process. Thank you.
Great, thanks, Steph. Lots of lessons there. Tiffany, go ahead.
Yeah, wonderful. So just to add on to from what the lessons learned from Kenya and Zimbabwe, some of our lessons in Ghana were really focused around commodities and budget and future iterations of PrEP implementation. So the commodity question is still ongoing. And luckily through this consultation with NACP and GAC, really driving the process with our global partners, WHO, UNAIDS, and with the implementers on this committee, we were able to integrate commodities into the Global Fund proposal. Because at first, when we started these discussions, PrEP commodities were not a part of the Global Fund proposal, which procures a large portion of the commodities in Ghana. So, you know, that's a basic building block and the lessons learned through our implementation process, and just having the advocacy on getting commodities available for PrEP implementation. Also, what we were learning through this process is fine-tuning eligibility of PrEP. We were seeing that, you know, we were maybe focusing a lot on that behavioral risk assessment and some were coming to initiate PrEP, but they might have seemed as low risk, but when in actuality, part of the guidance and the training, which is maybe a fine print, is if someone comes and would like to start PrEP, we can actually initiate them. And another is about lab cost. At this point, NACP is not covering lab costs for initiation. And so now we're in discussion about how we as a project can cover those costs, and also as advocacy at the national level on providing lab tests for everyone, so there's not a barrier for initiation. So those are just some fine points on what we're learning through the implementation process, in which we hope to have this national level committee for advocacy in a place of discussion, so we can integrate and fine tune all these components into that national level framework. Thank you.
Thanks, Tiffany. And yeah, I'm glad you mentioned the risk assessment. I think it is really important to make sure that that isn't a restrictive process, as I think sometimes it can be in how it's implemented. Aubrey, can we go to the next slide, please? So I wanted to open it up for questions for any of the presenters or experience shared in Ghana, Zimbabwe, or Kenya. And feel free to take yourselves off mute to ask questions, or put them in the chat if you have any at this time. And I know based on the discussion earlier, the poll earlier, some countries are in process of developing national implementation plans. Others haven't started yet, and some countries have them already. If you are not from Kenya, Zimbabwe, or Ghana and have a plan in place already, we'd also love to hear any of the input you have to share on these questions. If there's any differences or different lessons learned in your plan development process, it would be great to hear them too. While people are thinking, I can start with a question for all of the presenters. And that is, now that you have these implementation plans in place, can you describe a little bit about how they've been used since they've been finalized? Tiffany, maybe we can start with you. I don't know if you could share a little bit about what's been done with the plan to date.
Sure, we use it as a guide, and we are constantly reviewing it and fine tuning. Just on the other day, we were a discussion on event driven, were discussed on if we were going to expand implementation on ED PrEP. And so, those are discussions. We were looking back at the implementation guide to see what it was saying, seeing that it really was maybe insufficient to start that implementation strategy and maybe fine tuning it. But of course, at this point, NACP still is hesitant on committee to national scale up, and didn't really feel comfortable on at this point. So it's a continual discussion, and we're looking at it, especially with monitoring and evaluation as well. FHI has custom indicators, there's the PEPFAR indicators, and looking at these two different approaches and seeing how really the country, not only the program, wants to map out the cascade and monitor and track. Thank you.
Great,
Yeah.
thanks. Jeff. Oh, Patricia.
Yeah, so for us in Kenya, it's a guide just like Tiffany has shared, but I think also for us, it's really helped in terms of coordinating, especially like the research components, where if anybody said they had funding or they were applying for funding for any form of research in PrEP, we had a list of the different research gaps that were already existing. So we would easily just tell somebody to look at that list and see which of those areas they would be willing to write a proposal for. And even we also use this tool for advocacy, especially in terms of integrating PrEP into different service delivery points, including the youth-friendly services centers. That has continued to be in use even with the young advocates when they're advocating for provision of PrEP in the youth-friendly centers. So it's a tool that we keep referring to support with coordination and to streamline also implementation of PrEP.
Thanks. And Def, anything else you'd like to add?
Yes, so for us, this is also a document to monitor progress and what has changed, what should we modify. It's also a resource mobilization document, especially for our major donors like for PEPFAR, for CDC, for Global Fund. This is the document we use for anyone who wants to come in and support PrEP implementation, PrEP delivery in Zimbabwe, because it's already costed. And that's the reason we, ministry wanted it costed in the beginning, because it would work as a resource mobilization document for us. So it's been working for us in terms of benchmarking our targets, how we are performing, whether we are meeting our targets or we are not meeting our targets, and re-strategizing on what we need to do better based on the performance against the implementation plan. Thank you.
Great. Well, I don't see any other questions coming through. Why don't we go to the next slide, Aubrey? So the upcoming sessions, October 21st is PrEP delivery models, and we will be hearing from partners on different delivery models that they're currently using for PrEP rollout. In November, we'll be talking specifically about PrEP demand creation and PrEP communication strategies for national rollout. And then in December, we'll be PrEP costing and target setting, as I mentioned earlier. Just go back just a minute. And again, there is the registration for each of those on that link, and you do need to register in advance. Sorry, go ahead, Aubrey. And we talked about the PrEP Watch page. The webinars are all recorded and loaded onto PrEP Watch, where you can get the PowerPoint presentation or the webinar recording. And as we mentioned, I put in the chat that the Plan for PrEP Toolkit is on PrEP Watch, both in English and in French for access. And just before we go, go ahead. Let's go to the poll. It will be a question that just to make sure before we end. But please do, in terms of the poll, we want to know what date would be better for that oral PrEP costing and target setting session in December. With holidays coming up, it might be better earlier in the month, or we can keep it at the 16th, which is when it is currently scheduled for. So please take a look and let us know what would work better for you, and then we can revise accordingly. While waiting for the results to come in, Patricia mentioned something about the side effects on PrEP and knowing more about what the side effects are in order to answer questions from community members on PrEP while on fieldwork. So we can definitely follow up on that. I think, unless you want to address it quickly, Patricia, here, we can follow up by email afterwards as well. I'm going to end the poll. About half the people voted, and there is a strong, whoops, oh no. There was a strong preference for December 9th. So we will look at moving that to December 9th, confirming that date. Thank you very much, everybody who provided input on that. We are at the top. We are at the top of the hour, or the half hour, I should say. So I will. I can follow up specifically on your question about side effects in PrEP and provide some resources on that directly by email. So I think I have the registration, and hello to Patricia's son there. Hi. Okay, well, thank you very much, everybody. Thanks for joining. And we hope to see you again in October on that next session on community PrEP.
Thank you.
PrEP delivery. Thanks, everyone.
Bye.